we are going to revisit a topic that we've been talking about for a while now, since June, when it comes to the power hours, and that is health, equity, and racism. And we will continue to revisit this topic and approximately on a monthly basis, if not more. We are very excited about today's guest. We have a group of guests in the studio that some of you will recognize, and we also welcome some new guests that we hope also will be part of this conversation going forward as we continue. As a reminder, Power Hour is offered to you by the KNF Institute for Physician Leadership with the North Carolina Medical Society. My name is Christina Natterdog, and with me today I have also my colleague Aubrey Cuthbertson, as well as Franklin Walker, who is, as always, our eminent moderator of these sessions. I do want to remind you that the Power Hour started as a way to really focus on conversation, collaboration, and above all, community. And I want to thank any of our returning guests today, and as well welcome anyone who's tuning into this session for the first time. We really appreciate you taking the time to be here with us today. We do want you to know that we today ask you to post any questions you have in the chat. Sometimes we say you can unmute yourselves. We do have a lot of guests participants today, which is fantastic. So just post any questions that you have in the chat, and we will make sure that we get to those. The session is recorded and will be available about midweek next week on the KNF Institute for Physician Leadership landing page. Without any further ado, I'd like to hand it over to Franklin Walker. And again, a big thank you to our guests today for taking the time to be part of this. We value your participation enormously. Thank you so much.
Super. Thanks, Tina. Welcome, everybody. Hope everybody that's on the panel and listening today had an enjoyable Thanksgiving. I know it was a little different for everybody. So we're going to continue our ongoing conversation about health equity and racism in medicine. And our goal today is to kind of move the ship over a little bit, move the conversation toward tools and what we can do to address this in our workplace and in our society. And we've got a great panel again. A lot of these folks have been with us in the past. So let's just jump right in. I'll start at the top with Diane Johnson, please. And can each one of you, as I call on you, give me a little bit of background on your work right now?
Hi, good afternoon, everybody. Diane Johnson, and I'm very pleased to be here. So I am a career public health professional. I currently am the Chief Communications and Public Health Officer at the Miss Porter School, which is an independent and boarding school in Connecticut, although I'm based in Washington, D.C. But I have a long and storied career in international health. I did a number of years work in international HIV and infectious diseases. So this coronavirus pandemic is quite exciting from the public health perspective, although I know it's very challenging from the personal and individual perspective. And I'm also currently adjunct faculty at both the UNC School of Public Health and also at the Georgetown School of Continuing Studies in the Health Policy and Management program.
Super, thank you. Dr. Smith, how about you?
Good afternoon. I'm glad to be here and thank you for the invitation. I am a family physician, 28 years in Rayford, North Carolina. 17 of those 28 years, I've been operating my own independent rural medical practice. I also had the honor of serving on the North Carolina Medical Society Board of Directors and co-chairing the Racial Reconciliation Task Force, as well as the Health Equity Task Force. I've also had the honor of serving on the American Academy of Family Physicians Subcommittee on Health Equity, as well as the Family for America's Health on the Committee for Health Equity. And so I look forward to our conversation today.
Super, thank you. David McIntosh, how about you, please, sir?
Thank you so much. Hello, friends. My name is Dave. I'm really excited to be back and share with you some more stories and some more practices. So the things that I do in my role I am the Chief Inclusion and Diversity Officer for our health system. And so I do, my work can kind of be bucketed in a couple of different ways. First, it's really, there's a component of it that's capacity building and training. And so that's professional development around race, identity, diversity, inclusion, and those factors and characteristics. Another bucket is climate and how people are allowed to be included, valued, and respected in our health system, so how they show up in our health system. And then another one is how do we affect change? And so what is the intrinsic motivation to go out and do the work? And so that all three of these things are kind of in line with one another. And so, and it's very rewarding. And we've got a number of initiatives that I'm happy to chat about. The other thing that I do is I do a lot of work with the AAMC, which is the Association of American Medical Colleges. And so there I do a lot of work also around diversity, equity, and inclusion. And so pretty soon here, we're going to be releasing some standards that are diversity, equity, and inclusion standards for medical school students, residents, and early career faculty. And it's kind of bucketed in those diversity, equity, and inclusion outcomes, things that you should be competent and capable in around those three areas. So really, really exciting work coming out. Thank you.
That's awesome. Thank you, Dave. And Dr. Julie Freischlag, are you with us now?
Yes, I am.
Welcome.
Thank you. So I'm the CEO of Wake Forest Baptist Health and the Dean of the Wake Forest School of Medicine. And also I'm the new Chief Academic Officer of Atrium Health. As you know, we have a new strategic partnership with Atrium Health and planning on beginning a regional medical school in Charlotte. So we'll be growing to a Wake Forest School of Medicine in Charlotte. Same school, both sites. Dave works with me, which is wonderful as we've gone forward with our journey, learning more about how to be better inclusive, not only in our educational space, but also in our patient space. COVID-19 has really pointed out disparities in certain patient populations. Might be very complicated why that is, whether it's where they live or how they wait a while to come see us because of lack of access or fear of losing their job or fear of being diagnosed. And then also what kind of underlying diseases they may have, whether or not it is obesity, diabetes. And we also have seen that women do better with this disease than men. So it's not only race, but it could be also gender as well. So I'm here to have some comments, but also mainly to learn from all of you.
Super. We welcome you. Artina Dawkins, welcome back.
Thank you, Franklin, and thank you so much for having me back. I'm super excited about today's conversation and what I'll be able to glean from it. Also want to acknowledge my colleagues and friends. So happy to be on the same stage with the CEO of Wake Forest Baptist Health, where I'm employed. So great to see you, Dr. Freischlag, and Dr. Dave McIntosh. We are colleagues as well. Kathy Paling is on here, and Dr. Brenda Latham Sadler logged on for a little bit. Not sure she's still here, but again, thank you. So a little bit about the many hats, leadership roles that I wear within and outside of the institution. So within my Department of Orthopedic Surgery, I am the program manager of orthopedic residency. I advanced from residency program assistant to coordinator to program manager. So I know the ins and outs of how to manage a residency and fellowship program well as how to navigate through the different organizations that dictate what advancing through those programs looks like. I'm also the co-director of diversity and inclusion, which is a role that I've had since July of 2019. And in that role, I spearhead multiple departmental efforts, including training on how to minimize bias in the recruitment of residents, partnering with the Inclusion and Diversity Office to conduct active bystander training. And I've also helped to establish a code of conduct for residents within the institution, but outside of my department, I am the founder and program manager of the Kennedy Hopkins Scholars Mentoring Program. It was launched in March of 2018, and there was a letter that we had honoring the faculty mentors who participated in that pilot. And Dr. Freischlag was one of the signers on that letter, along with Dr. Latham Sadler, Dr. Mary Claire O'Brien, because we wanted to let them know that we appreciated them participating in this successful pilot. And so we were able to build the program from a pilot of 4 departments to an institutional offering of 70 plus departments at Wake Forest Baptist Health. And I'm also an affiliate faculty of the Maya Angelou Center. And one last thing, outside of the institution, I have a national role as president-elect of the Association of Residency Coordinators in Orthopaedic Surgery. And in that role, I'm the first African-American to hold that position, as well as the first president-elect to have a PhD. And in this role, I have introduced the organization's first national poster session, which represents the 200 plus orthopedic programs across the country. So thank you again for having me back.
We're glad to have you. It sounds like you've added to your portfolio since the last time you were with us.
Yes.
Dr. Phil Brown, better late than never. Good to see you. Can you tell us a little bit about yourself and your work, please, sir?
Thank you so much for tolerating my tardiness. Got a little bit overtime there on some of our integration planning meetings. But at any rate, you know my name. Franklin just said it. I'm the chief physician at New Hanover, but I still a lot of times think of myself as that examinee. I've taken general surgery boards with Dr. Freischlag as my examiner. And there's a funny story about me walking into a closet after that exam, and we'll save that for later. But that heritage goes way back, and surgery history is deep and rich. And Dr. Freischlag, it's good to see you again. I feel a lot more comfortable around you than I did that day. But my responsibilities as chief physician at New Hanover and also, I guess, president of North Carolina Medical Society really are all about a focus on what we have to do to improve the health of North Carolinians. Now, when I'm at home and doing my work there, it's in New Hanover County in southeastern North Carolina, but at the state level, it's for everybody. So I'm profoundly engaged in what it means to achieve health equity. This has been a multi-year journey for me, for our organization. Everything that is diversity, inclusion, and health equity began as an idea with a small group of us that started it only 4 or 5 years ago. And we've come a long way, but we're absolutely on the right track. And I'm so really honored to be in a group with the amount of expertise that is here. Because certainly I still consider myself very much of a learner, but also as somebody who has the potential to be important in this journey. And I really do deeply believe that understanding the impact of racism on health, understanding what it takes to truly achieve health equity is really the key to prosperity for the state of North Carolina and the future of our profession. So thanks for having me be a part of this.
Super. Thank you, sir. Well, let's jump right in. I want to bring up something that was brought to my attention early this morning or late last night, depending upon when I got to my email. It was a memo that came out from the AMA on November 16th of this year. And it states that racism is a threat to public health. And the AMA goes on to say that they recognize that racism negatively impacts and exacerbates health inequities among historically marginalized communities. Without systemic and structural level change, health inequities will continue to exist and the overall health of the nation will suffer. I'd like to get you guys to react to that. And I think I'd like to start with Dr. Karen Smith.
Thank you. I really appreciate the fact that the work that's occurring in North Carolina is in line with what is occurring nationally. And the AMA being a voice of many specialties, the House of Medicine, to have this statement come out of the special session that occurred in November and recognize the work was actually occurring in June earlier this year. The other thing that I wanted to highlight on the new policies that was adopted, also recognizing racism in its systemic and cultural, interpersonal, and other forms, acknowledging that primary drivers of racial health inequity are systemic. And I think there were two other ones, recognizing race as a social construct. So the AMA certainly wanted to highlight that amongst the physicians as well as learners and the PAs and other folks who associate with the AMA. And then the other part of ending racial essentialism. And what does that mean? That means to counteract the notion of racial essentialism, which identified in a resolution presented at the special meetings, the belief in a genetic or biological essence that defines all members of a racial category. So I think the bottom line in terms of my comments is it's nice to see that the national organization has taken a lead and is providing us with resources, allowing us to hold a conversation in our state, but also converse with other thinkers in healthcare so that we can finally arrive at those policies that will make a difference for each one of us.
Super. I think I'd like to go to Dr. Brown because you are the current president of the North Carolina Medical Society, and you're overseeing a lot of our efforts in this area this year, which is setting us up for moving forward on a lot of things. And so I think it'd be important to hear from you about this. You're muted.
I think it hits me a couple of ways. I'm glad. It's a very important statement. But on the other hand, man, it's about time. And so I think it sets the stage. I think that's wonderful. We still got to do it. This whole process is about action. It ain't about talking. And so that's really where we are. I'm highly encouraged based on the direction of our society in North Carolina, of many of the systems and individual practices around North Carolina that are now resetting in a manner that actually is going to allow us to address this in a meaningful way. Our job in leadership is to really make sure that we're scrutinizing the impacts of those actions. Because we can look at history and understand that many well-intentioned things played out in a way that didn't accomplish what it was intended to accomplish for equity. Otherwise, we wouldn't be where we are now. So that's really a big part of the leadership role, is not only to continue to inspire this thought process to become action, but also to set up the right measures, make sure it's doing what we think it's going to do.
Super. Now I want to move away from the clinicians per se and talk to Dr. Dave McIntosh, because you're overseeing a lot of action there at Wake Forest Baptist. So what's your reaction to this statement from the AMA?
I absolutely love it. And let me also say that one of my former students is one of the people that was able to contribute to this. And so it is just really heartwarming. He was texting me during the meeting, like, this is going to happen. This is a thing. And so it was just very, very, oh my gosh, it gives me goosebumps. But this is exactly where our professional organization needs to be, right? I can remember having the conversations with leaders at my previous institutions about this idea of the social construction of race, and people really pushing back on that. And to have the major organization embracing the data in such an important way and really putting it out on Front Street that we're no longer going to use race as a proxy, and that this is a bad proxy for genetic information or from country or space of origin or all these other ways that we use it in problematic ways. It's said by Max Weber. Anybody who studies organizational economies knows Max Weber. And I'm going to butcher the quote, but he said something like, every outcome that is seen is the product, or is that, no, doggone it. Every system is perfectly designed to create the outcome that is seen. And so what that means is when you consider the social construction and the health disparities that we see in our society, they are the perfect outcome of the system that we have created that has created those outcomes. So if we don't actually start examining the ways that we create these outcomes, then we're putting band-aids on a huge problem. And so I love that the AMA has said this. I can't wait for all of our organizations to lock arms and really make a difference in this.
Dr. Dawkins, can you respond to that?
Yes. So I think, again, I echo what has been said already in response to this question. I really like what Dr. Brown said. You know, it's about time. Now let's do the work. There's been a lot of lip service over the years in different respects of, you know, here's this great statement. Everybody feels good about it, but nothing changes. Salary equity, inequity remains intact. Racism remains intact. So now it's about time to start putting our money where our mouth is, get our hands dirty, and do the work. And when I was reading this article, and I want to pause for a second, I forgot one of my colleagues, Dr. Mike Lischke. Thank you, Mike, for supporting us. And if I missed anyone else, we thank you for supporting us in today's session. So without radical change, healthcare inequities are going to continue to exist. So a couple of weeks ago, I attended the AAMC's national meeting, and one of the radical things that the AAMC did was they renamed one of their most prestigious awards, which was previously called the Flexner Award. And so I'll read the title of their release about it. It says, the AAMC renames Abraham Flexner Award for Distinguished Service to Medical Education. And so it was, that award has been renamed to the AAMC Award for Excellence in Medical Education, effective 2021. And so these are the kind of things that we need to do as an institution, not only call it out, but really undo and fix the things that have already been done. And so talking about the Flexner report, so the Flexner report resulted in 5 of 7 of the HBCUs that were in existence in 1923 being closed. And so if we really want to do something, if we really want to follow through on an action, why don't we reinstitute those 5 HBCUs and put them back into existence and pour in money and funding so that they can be successful. And so I really appreciate this article, and I love how it demonstrates fearlessness, as Tina and I were talking about a few minutes. And I think institutions need to take that stance to be fearless, to institute anti-racist policies, to even relook at policies, at procedures, at processes, even in HR, salary bands, relook at them through a lens of racial equity to see, are there fallacies, are there discriminatory practices that are hiding in these processes, and begin to make substantive changes on all these different levels.
Super, thank you. And I think I'd like Dr. Froschlog's opinion on this AMA business.
I agree with everyone's comments. And actually, Dr. Dawkins, I was actually going to bring up the change that the AAC made. I'm on the board of directors now with our new leader, David Scorton, who has been quite brave. I mean, he's come out not only on this Flexner report and giving the data out there. Not only was there issues with the historical Black universities, but a lot of gender discrimination also in those reports that we sort of decided to file and go forward. And I never really thought of the Flexner report of anything but positive when I was in medical school, because they made it seem like they had made schools better, but perhaps they just made them like Hopkins. And I spent a lot of time at Hopkins, and not everything should be like Hopkins. Everything's different. Whenever I told people as they left Hopkins, I said the 3 words you should never use at your new institution is "at Hopkins we," because that doesn't apply where else you work. I think we need to not only have institutions come out like Dr. Dawkins said, but we've got to give them the tools. And what David has really worked with us with our racial equity task force is to look at your own data. We've looked at our patient data, our employee data, our profession data. We all have lots of data looking at where our racial inequities are, where do your ethnic minorities work in your institution. I'm not proud of ours. We have a lot of work to do, but then you have your data and go forward with working groups. And then you need to give people the language so they're able to be an ally. I've learned a lot in the last 6 months because I was very proactive and loud about women, because I felt I had competency of women in medicine and women being in leadership positions. I did not feel like I had competency in race. And now I feel like I can be a great ally. I can have that conversation and I can encourage others to have those conversations and use your data to go forward. So more to come from our task force. And the last thing I'll mention, and this is really Dr. McIntosh's work, is in our cabinet, which is about 107 people, actually Dr. Litchke's in that, we have them working in teams of 6 to 7 with a facilitator talking about race so that they also feel competent, they feel they can be an ally. And those groups actually have had a secondary consequence, which has been great during the COVID-19. They actually have formed sort of a little group for themselves. We're all so lonely because of COVID-19. So now they have 7 or 8 people they talk to, and I'm going to use those same groups to do some of our strategic planning with Atrium next year. They know that group meets every month and they sort of enjoy seeing each other. So they'll remember their work on racial equity and their work on racial language as something very positive during a time that was a very scary, lonely thing. So I'm hoping that actually those groups will do other things and be able to go out and teach who they teach, like Dr. Dawkins does and Dr. Brown does, so that those that come behind us have the language as well.
Super. So let's take a look at some things, some actions that have happened at the societal level. As you guys may recall, back in June, Governor Cooper established a task force to address racial equity in the state criminal justice executive forum. Executive Order number 145 sets a path to eliminate systemic racial bias in criminal justice. We must acknowledge racial inequities in our systems of law enforcement and criminal justice and then work to eliminate them. Now, it's been 6 months since Governor Cooper made that statement. We've gone through a lot in 6 months. There's been an election. Where do you guys think we are now? And are we addressing some of the right priorities? Diane, I'd like to start with you, please.
Hi. So I think that it's definitely a good start. I think one of the things that is so important to consider, especially as we think about this as a public health issue that has tentacles into other spaces, is that as a country, we've never really given recompense for the atrocities that have occurred to communities of color, right? So we can look back all the way to the early 1600s when we legislated what could and could not be done to Black women and their bodies. And the only group in this country that really ever was given some sort of remuneration for slavery were the slaveholders. So as we consider how do we move forward, how do we recognize racial inequalities, we really need to have an atonement for what has been done, because that's a point where we can start to heal, and that's a point where we can start to move forward. A really great book, if anybody's interested, is called Killing the Black Body by Dorothy Roberts. And it literally chronicles just some of the things that have happened historically and why we see these inequities. So as we're moving forward and we consider how do we make meaningful efforts to make change. I mean, I think it has to be structural, right? So we've got the health disparities, but then we've got the structural components of health disparities. And some of the ways that we can do that are obviously the task forces that we see. Really having groups look at diversity, inclusion, and equity, and how do you break down those things that have not worked and really build them up into something that can be successful. I can just speak to some of the things that we're doing at UNC in the School of Public Health, which is where I'm currently adjunct faculty. Part of our core curriculum is based on looking at inclusion and equity. It's built into all of our classes, and we actually have a philosophy called inclusive excellence. And so part of that is understanding how racial inequalities have at a systemic level been habitually communicated, and making sure that as we are putting out these next cohorts of public health professionals and people in that space, that they are able to identify learn the cultural humility, learn cultural competency, identify their privilege, so that as they're going out into the workforce, as they're going out into other communities, they're sort of helping to break these things down. So I think that that is a really major component of where we need to go. And this is sort of at all levels. With regards to medicine, certainly the statements have been coming out now about racial equality, but in the public health space, we've been doing this for a really, really long time. So I think that is certainly one piece of acknowledging the racial inequalities.
Super, thank you. Dr. Dave McIntosh, your comments on this.
Thank you. I just love what Dr. Johnson just shared. I think that is so spot on. And one of the things that I fear when we have these conversations is that we decontextualize race to only count now. And if we don't actually broadly consider the systemic factors and the ways that race is woven into every fabric of our society, then you're missing the point, right? And so that's, and actually I get nervous when I hear somebody say, when we're having a conversation about race, try to push me to make it immediately clinically relevant. I recognize that things do need to be clinically relevant, but we also need to consider the broader factors. So when I think about how race intersects with our housing system, our education system, our employment system, our legal system, our health, and by all means, our health system, all of these systemic factors, when considered in concert, it just so happens that for every one of these systems, folks of color are at a dramatic disadvantage. And until we consider all of those factors in concert, we're not going to be able to elevate somebody's health because there are so many other factors that are pulling people back. And so, and there is a really strong historic precedent. And I love, again, everything that was just said. And I love adding that kind of critical legal discourse in there where we can look at the naturalization cases and understand that at one point in our history, people had to sue for the opportunity to be white. And it's because there were real tangible benefits from our society for being white. You could be a homesteader and you could get free land from our government. Like there were things that were exclusionary, and those are wealth building opportunities. So when we hear people say, oh, well, I just work really hard, everybody works really hard. Let us consider that some people work really hard and started way up here. And so I love the question and I love this this Thank you.
Super, thank you. I want to move on to a different topic about testing. And this was implemented in July when the North Carolina Department of Human Services, Health and Human Services announced plans to increase the COVID testing in underserved communities. We talked a little bit about this at the time we were having another discussion on health equity. To date, of the African American population in North Carolina, which is 22%, the numbers have adjusted downward 14.3% of the cases and 19% of the deaths. Do you think this is a reassuring trend? And what have your respective institutions done to address this inequity, not just in testing, but in other areas of health disparity? I want to come back to Dr. Brown because in an earlier conversation, you and I were talking about the lack of testing several months ago in New Hanover County, maybe around the public health department. And so I want to come to you first with this question because I do remember that was a problem in your backyard.
Well, from a testing standpoint, we still have health department problems, but that's not necessarily what drives the disparity in testing, right? That's just one component. They're deficient for everybody.
Yep.
And so one of the things that we did specifically and conscientiously was outreach into our African American community. But I can tell you, we messed up, right? Because what we initially neglected, and luckily we had the relationships that helped with it, was we didn't go deep enough into the Hispanic community, right? So it shows you a level of where we are in our journey of competence, right? Like we're only consciously competent. It's not become a part and parcel of who we are. As soon as we lose laser focus on equity, it's still not a natural part of how business is done. And so when we start talking about systemic and structural, that's an example of how that plays out. But we have made great efforts to try to compensate for those things through conscious efforts, and through, mainly the thing about COVID for us has been communication, right? And making sure that we hit every community with the right level of communication. And luckily, from the relationships that we developed over the last number of years in our community with different segments, we have found those community leaders to be very engaged in helping us get the message right, and more importantly, helping carry that message. Because, there's nothing fancy about the medical care for COVID-19. Not really, not until you get in real trouble, and then you get all the fancy ICU stuff. But the real truth of it is, this is public health 101. This is prevention. This is how you do that. What I have found is that those relationships that we have developed over time in many of our communities have been incredibly helpful, because the communities themselves have carried that message, and it not only spreads it, but it amplifies it, and it gives credibility. So that, to me, that's the real lesson around that. Is it is not as much what you bring into a community as it is how much you empower the leadership within each community to do what's necessary for them to flourish. And then there's a middle ground there where you have to help understand with clarity what that is in a given condition, right? But there are going to always be factors that people from that community know a heck of a lot more about how to get done than I would. And the tighter our relationships are, the more effectively that's done.
Super. Dr. Smith, I want to leave the coast and maybe a more metro area and let you address this present question, because you're in Rayford, a much smaller population down there. So give us your thoughts on this.
Very good. The three words that we want to keep in mind is testing, tracing, and treatment. And we know that's coming out of our public health discipline. And in the rural area, we fell behind with the initial testing. I gave the story before of how we had to just scour the region to come up with 25 test kits because of a local outbreak. And so there have been changes, and new entities have come in to assist with the testing. I am privileged to say that the Old North State Medical Society has certainly reached out in the rural areas, and we've been able to increase testing in those areas, and wonderful partnerships have taken place. But we're still behaving in kind of a silo, meaning the health department is doing testing, Harris Teeter is doing testing, Old North State Medical Society is doing testing, and it seems like everybody may have a little bit different twist on the protocol. And so the public gets confused. I actually have an elderly couple who were able to determine the test sites off of the website that was listed for the state. And they made it their business to travel to the different testing sites, and they were getting tested every 2 weeks. And then I have people who come in and say, how can I be tested? And it's like, you need to connect up with the elderly people, because they seem to know what's going on. Our geriatric population. And so it would have been great if we had a unified response, if we had the leadership that would allow us to provide those tests, do the tracing, get the treatment. And I really feel like we would have been able to reach far greater numbers than what we've been able to do. The rural area is still having difficulties, just as everywhere else in the country. I was given the total of people who have died in our county as of yesterday was 31. There's a funeral taking place tomorrow and that I'm aware of. And then I get word from the funeral home that we have 6 people who are deceased who have gone because of result of COVID. So we have too many deaths that are still occurring. There's more work to be done.
Super, super. I'm going to ask another question. At the organizational level, your respective organizations have taken active steps in addressing this issue, and we've been talking about this for several times. What spurred you to explicitly address equity and racism in your organization? How and where did you start? Dr. Dawkins, can we start with you?
Yes, Franklin, thank you for this question. And before I dive into that, I want to quickly kind of reframe the previous question about the COVID-19 testing. I'm not a clinician, so I have a bit of a different perspective about that. When we talk about underserved communities, what jumps out to me is the word underserved. I'm African-American female, so things that deal with race as in regards to Black and Brown folks, that I'm faced with that on a regular basis. And so I looked up the word underserved. So according to Merriam-Webster, underserved means provided with inadequate service. And so I would frame our thinking about this. And I heard what Dr. Smith said about, for hopefully we never have to go through this again, but there needs to be some type of better way to administer these types of tests so that those who really need it can get it. So I would reframe it in this way. If the same communities are always provided with inadequate service, which is the definition of underserved, what are the reasons why these communities perpetually receive inadequate service? Who are the providers? What is preventing these providers from proactively providing needed resources to these communities based on the known needs? What is preventing providers from providing enough resources and support so that they no longer have to be referred to as underserved? So I wanted to kind of throw that out there for the previous question, because I think there's other underlying questions that need to be asked. And so as far as the question that you just asked, Franklin, about on the organizational level, so as I alluded to before, I explicitly address equity and racism because as a Black person in the US, I'm faced with defending my Blackness and having to prove my worth on a regular basis in different instances. As a Black woman and as a Black person in a predominantly white environment, I'm consistently bombarded with instances of inequity or racism, whether it's my own personal experiences or the experiences of colleagues, friends, or those who look like me. And I must say that as I was preparing for today's session and reading over things, it was incredibly hard for me to focus because whenever I read about how the HBCU schools were closed, and as Dr. Freischlag said, it also had ramifications, the Flexner report did, for gender discrimination. It's so hard to focus because I think about things that have happened in my career, in my life, where I'm having a great day minding my own business, being awesome or whatever I'm being, and boom, here's an instance of racism. Here's a mistreatment. Here's an unkind word. Here's oh, it's great to see you here, kind of thing. And you're like, you don't even have you don't know how to respond because you're caught so aback. My parents grew up during the Jim Crow era and the Civil Rights Movement. So that's the lens through which I see a lot of things. My mom she's a retired high school teacher. She taught world history. She was the first African-American female to integrate the high school. And so these things that are going on, they're not new. And they're embedded in my history, which is great. So we don't repeat the things that we have done in the past. So what spurred me is that there's not enough being done to ensure that racism isn't pervasive at my institution, in our society. As Dr. McIntosh alluded to, if you look in every aspect of society, the arts, the justice system, government, education, community, racism is pervasive in language and what's taught. Let's talk about history books. What's missing about slavery? The horrors of slavery that's not missing in slavery. As far as the history of slavery, it's not included in history, so our children aren't learning it in the depth that they should. And so, along my same point of there not being enough done to combat racism. So whether it's in regards to inequity in pay, if that's how racism manifests, If it's inequity in professional advancement opportunities, hiring practices, inequitable treatment of residents and fellows, that's the realm I'm in, so I see that, or racism in the recruitment process. I was determined to be an instrument of change in whatever way that looked like, being creative, being innovative, having conversations, collaborating with those who could do things that I could not. That has been kind of like the what has pushed me to do what I've done so far and what I plan to do in the future.
Super, super. Now I want to bring it back down to an individual level. And at the individual level, the people in your respective organization, as they enact and embody the strategies that you and your teams have outlined, what has changed for them? Okay. So want to think on that for a second. And I want to start with Dr. Froschlog, please.
I think what happened at our teams really was the ability to announce very quickly that we were going to start this racial equity task force, and that it's not just for a piece of time. It's going to be part of who we are as we go forward, and it's not something that's just a program or a project for this year. That it's something that is similar to any other very important group that you have working, whether it's on curriculum or policies or looking at quality indicators in the hospital. All of that's so important that this will go on forever. We also put some money in it. You know, when you look at things, you need to put some money in it. So we actually are using some of our public health researchers to look at the data, like I mentioned, and then look at what kind of things can be helpful to get better, so that you don't have to hear or have those experiences that Dr. Dawkins has, that people are wise enough and understanding enough and have abilities so that we can go forward in a way that's very inclusive. And I'm very lucky to have Dr. Goldie Bird running our Maya Angelou Center, who actually has experience in inclusion and had done a lot of work before we started the task force with our community, because I actually think each community is the way you're going to help that, whether your community is your city, your town. You could all argue that Wake Forest Baptist is a city. It's 20,000 people, right? And that we need to work with that. And now we're partnering with Atrium Health, which gives us, another 50,000 people. So we're really 70,000 people, all mostly trying to do the right thing. You know, most people come to work at the health system to do the right thing. There's a few that maybe don't. They come and cause endless trouble and go home. But most people come to do exactly that. So can we enable them to make that happen? So utilizing resources and then being very public about things that we found, similar to what happened with quality, when we actually pointed to issues with wrong site surgery or looking at surgical infection, team training in the operating room. Once we pointed our finger and put a light on it, it got better. And then pretty soon, when I go into an operating room now, I couldn't even imagine not doing a timeout, where 10 years ago, people said, I'm not doing that. I don't need to do the timeout and identify this. I do everything perfectly. And as we found out, that wasn't true. And now you wouldn't even start without being there doing your timeout. So I think as we go forward, getting this part of our culture so that we understand how to be accepting. I think COVID-19, there's a list of things that I tease that my group knows. That I said, what has COVID-19 done for me lately? And it's not a long list, but it has required people to stay home, right? People aren't traveling. I don't have people going to meetings. They actually can pay attention, and they need some projects to work on and some thoughts, whether it's Atrium Partnership, whether it's our Racial Equity Task Force. I think that this is the time that we can shine light on it, because people are seeing the differences in the treatment of the disease and the outcomes according to race and poverty levels. And therefore, we actually need to look at that. And they have time to do that and feel similar to what Dr. Dawkins says, that it'll be important work, that as we go forward, it will be important work to take our community into a better place.
Super. Diane, I want to get you in on this question, because you've got probably a little bit different thought process about it, given that you're not a clinician, and, you know, your affiliation with UNC and your other affiliations. So I'd love to hear from you on this.
Yeah, sure. Thank you for asking. So there are a couple of things. I think I'm a formal background in public health, but I'm also currently a doctoral student in the Gilling School. So one of the things that I have really been super proud of is how diverse my cohort is. And again, going back to how do you structure things? The School of Public Health has taken this very seriously. I also did my master's there 20 something years ago. So I'm now sort of seeing the school through two different iterations and two different lenses. And when I was a master's student, I was one of two Black students in my class. We had a Latina woman, and we're all friends now because we kind of did like the Black people now, like, I see you, but we didn't really talk about it because that's not what you did 20 something years ago. Now, you know, my cohort, there's four of us who are Black, there's two Asians. It's very diverse in terms of women and men. So there was intention in how the cohort was designed as those of us who are working professionals and going out into other spaces. So I think there has to be intention behind it without apology. So that's one thing. I think that also, as I think to, I used to be the chief communications officer at a hospital here in DC that has since closed. But even when we were there, because we served an underserved population, it was a Catholic mission-based hospital. We had $24 million in uncompensated care every single year, but it was our mission and our mandate to serve that population however we needed to do that. I also think that as you're considering how do you go about this, it has to be institutional, right? So in my current role at an independent school where I have like the health piece because we've got COVID and we're trying to bring kids back to school and not have outbreaks. I also have the communications piece. Somebody spoke to that earlier. How do you message that? I think it was Dr. Brown who said that. How do you have the right message to the right audience so that it'll resonate with that community? But it has to be across platforms, right? So with the school, we have to include our board of trustees, right? We have to include our alumni. We have to include the community. So what can the students do in their day-to-day that is actual anti-racist efforts? And how do we mandate that the alumni do this? And so with the board of trustees, actually all of the committees have to have an equity and inclusion component to what they do. So we are building this in from the very, very top levels all the way down to the student population. So I think that as you consider that, I just was taking some notes also earlier when we were planning. We have, for the board, we are working with a financial company that we know is actively investing in communities of color. They've got a new venture capitalist initiative that's put $30 million into minority and women-owned businesses. We have, with Dr. Rodney Glasgow, through the Glasgow Group, we've had sessions with the Board of Trustees, and these are some very, very influential old school money kinds of people looking at what they do and how they're moving forward. As I shared our alumni engagement, we have a diversity, equity, and inclusion subcommittee of the alumni development piece. Within our students, we have anti-racist educators, Association for White Anti-Racist Educators. In our staffing, 3 members of our executive team are of color. We've changed the language from the security force to campus safety. We changed their uniforms. It's now led by a Black woman. So all of these kinds of things create an environment where we illustrate what our expectations are and what our mandate is starting at the very, very top. And so it really is sort of built into the fabric. And I think the other thing is that we take each opportunity, each time our community changes, we take that as an opportunity for belonging, right? Because that's really what equity and inclusion is about. It's about the belonging. It's not about you fitting, me fitting into you. It's about the you evolving so that all of us are part of that conversation. So I think that even the lens through which we think about this and the language that we use as a communications person, as a health communications person, the language and the words and the images are so, so very important. So those are just some of the things that we're doing sort of in some of these other spaces. And I'd be happy, I can talk about this stuff all day. So I'd be happy to talk to anybody offline about some of the work that we did when I was at NIH with the Office of Research of Women's Health, or at NIAID when we were recruiting for vaccine clinical trials for Ebola, for SARS. That was my job, was to do that recruitment and talk in a way that included the community and let them know that we need you in these clinical trials, even though these atrocities happened. So I think there's lots of different levels where you can make an effective change, but there needs to be that commitment from the very, very top, that at every single stage, from the oldest of the old to the richest of the rich to the least advantaged to the youngest, that's going to be a core tenet, a core value of the organization or the institution.
Well, Diane, that was an excellent answer, and you've gotten us right to the top of the hour. I think there's a great takeaway from this. We are certainly in an all hands on deck moment in this. And as Dr. Brown said, the time for action is now. I want to thank all my guests today. We had a great discussion on this. We look forward to seeing you guys again in the future. Aubrey, would you close us up, please?
Absolutely. We want to thank all of our guests for being here today. We really appreciate your time and expertise. The next Power Hour is going to be on December 18th at noon. This recording will be available next week on the KIPL website. And thank you all for being with us this week. We really appreciate it, and we will see you next time.